Hello, welcome back to the Irish Haematology Oncology Podcast, the show where we make cancer care a little less complex. I'm Eoin Tabb, your host, and as a pharmacist, we're always fascinated by how our bodies interact with the medications we use to fight cancer. Last week, we looked at the kidneys and renal impairment. Today, we're shining a spotlight on the liver, an organ that's often overlooked but plays a crucial role in how our bodies process systemic anti-cancer treatments. So grab a cuppa, get comfy, and let's chat about hepatic impairment and its impact on cancer care. So let's look at segment one, the liver. It's your body's metabolic powerhouse and detoxification center. Let's give the liver the attention it deserves. This organ, tucked away in your abdomen, is a true unsung hero, working tirelessly behind the scenes to keep everything running smoothly. It's evolved in an astonishing array of functions, making it a key player in maintaining overall health and, as we'll see, a crucial factor in cancer treatment. That liver, it wears many hats. So let's talk about that liver's role as a master detoxifier. Think of it as a high-tech filtration system, constantly scanning your bloodstream for toxins, drugs, and metabolic waste products. It's like a vigilant customs agent, carefully inspecting everything that enters your body and deciding what stays and what goes. The liver uses a variety of enzymes and processes to neutralize or transform these substances into less harmful forms that can be safely excreted. But the liver's talents don't stop there. It's also a nutrient processing hub, acting like a master chef in your body's kitchen. It breaks down the food you eat, converting carbohydrates into glucose for energy, storing excess glucose as glycagon for later use, and even synthesizing fats and cholesterol. It's like a bustling restaurant, constantly preparing and serving up the nutrients your body needs to thrive. And that's not all. Your liver is a production powerhouse, churning out essential substances like bile, which digests fats, and clotting factors, which are crucial for preventing excessive bleeding. It also produces albumin, a protein that plays a vital role in maintaining fluid balance and transporting hormones and drugs throughout your body. The liver and medications is a complex relationship. This is where things get really interesting. The liver is the primary site where many medications, including a vast number of chemotherapy drugs, are metabolized. This means that the liver is responsible for breaking down these drugs into different forms, some of which are active and help fight cancer, while others are inactive and need to be eliminated from the body. This process is incredibly complex, involving a network of enzymes and pathways that can be influenced by a variety of factors, including genetics, age, and overall health. It's like a symphony orchestra with different instruments playing their part to create a harmonious whole. So what happens then when the liver falters? What's that impact on chemotherapy? Well, when the liver is impaired, this intricate symphony can become dissonant. The liver's ability to metabolize drugs is compromised, which can have significant consequences for cancer patients undergoing chemotherapy. One major concern is increased drug levels. If the liver can't break down the chemo drug efficiently, it can accumulate in the body, leading to heightened side effects and toxicity. It's like the traffic jam on a motorway. The cars, i.e. the drugs, can't move as quickly, and the build-up can cause accidents, i.e. side effects. Another issue is decreased drug activation. So some chemo drugs are prodrugs, meaning they're inactive in their original form and need to be transformed by the liver into their active cancer-fighting forms. When the liver is impaired, this activation process can be slowed down or incomplete, reducing the drug's effectiveness. It's like a car with a faulty engine. It might still move, but it won't reach its full potential. But it's not just about metabolism. The liver also plays a role in biliary excretion, the process of eliminating drugs and their metabolites through bile. When the liver is impaired, this process can be disrupted, leading to further drug accumulation and potential toxicity. And let's not forget about blood flow. The liver receives a massive amount of blood flow, and when liver function is reduced, this flow can be altered. This is particularly important for drugs whose clearance is highly dependent on blood flow to the liver. And finally, there's the issue with protein binding. Many chemo drugs bind to the proteins in the blood, particularly albumin, which is produced by the liver. When the liver is impaired, albumin levels can drop, leading to an increase in the amount of unbound or free drug in the bloodstream. This can increase the risk of side effects, even if the total amount of drug in the body isn't necessarily higher. As you can see, hepatic impairment is a complex issue with far-reaching implications for cancer treatment. It's not just a single problem, but a cascade of events that can affect drug levels, drug activity, and the risk of side effects. That's why it's so important for us to have a deep understanding of liver function and its impact on chemotherapy. So let's see what happens when the liver hits a snag. Let's look at those types and causes of hepatic impairment. So when this incredible organ isn't functioning at its best, this is what we call hepatic impairment, or another word is liver dysfunction. It's like a kitchen where the appliances are on the fritz. Things start to get messy. So there are different degrees of hepatic impairment, ranging from mild to severe. So mild impairment. The liver is still mostly functional, but it might be a bit sluggish. It's like the slow cooker, right? It gets the job done, but it takes a bit longer. Moderate impairment then. The liver is struggling to keep up with its workload. It's like the dishwasher that's not cleaning the dishes properly. Things are starting to pile up here. And then severe impairment. This is the liver is severely compromised and its functions are significantly impaired. That kitchen is now on fire. Everything is out of control. So let's look at the causes of hepatic impairment. There are many reasons why the liver might become impaired. Some of the most common reasons can be chronic liver diseases. So I'll list off a couple here. So cirrhosis. This is a late stage of scarring or fibrosis of the liver caused by many forms of liver diseases and conditions, such as hepatitis and chronic alcoholism. The scar tissue replaces healthy liver tissue and prevents the liver from working properly. Then you can have hepatitis. So this is an inflammation of the liver. It can be caused by viruses like Hep A, B, or C, alcohol abuse, certain medications, and autoimmune diseases. And then you can have non-alcoholic fatty liver disease. This is a condition where fat builds up in the liver, often in people who are overweight or obese. It can range from simple fat accumulation, or steatosis is the medical term for this, to non-alcoholic steatohepatitis, or NASH is the acronym for that. And that involves inflammation and liver damage. And medications. And medications are another reason why the liver can become impaired. So chemotherapy. Certain chemotherapy drugs like methotrexate and 6-methoxypurine can be toxic to the liver. It's like friendly fire in a battle. The drugs are meant to kill cancer cells, but they can also damage healthy liver cells. And other medications, so some antibiotics, pain relievers, and other drugs can also cause liver damage, especially when taken in high doses or for long periods. And alcohol abuse. So excessive alcohol consumption is a major cause of liver disease. Alcohol is a toxin that the liver has to break down, and over time, this can lead to inflammation, fatty liver, and eventually cirrhosis. And there's other causes as well. So less common causes of hepatic impairment include genetic disorder, bile duct blockages, and certain infections. So let's look at the types of liver damage. In addition to the causes, it's important to understand the different types of liver damage that can occur. So there's hepatocellular injury. This type of damage affects the liver cells themselves, hepatocytes, and it can be caused by viruses, toxins, or medications. Then you can have cholestatic injury. This type of damage affects the bile ducts, which carry bile from the liver to the gallbladder and intestines. It can be caused by gallstones, tumors, or certain medications. And then you have a mixed injury. This type of damage involves both hepatocellular and cholestatic injury. The type of liver damage can influence the way the liver metabolizes drugs and the specific dose adjustments that might be needed. And why does this all matter? Well, understanding the causes and types of hepatic impairment is crucial. It helps us identify patients who are at risk of liver problems and tailor our treatment strategies accordingly. So take, for example, if a patient has a history of hepatitis C, we know they're at higher risk of liver damage from certain chemo drugs, and we can adjust their dose or choose alternative medications. Remember, we're not just looking at numbers on a lab report, we're looking at the whole patient, their medical history, and their current condition to make best decisions for their care. All right, so we now know that a struggling liver can mess with chemo. But how do we actually gauge how well a patient's liver is working? Unfortunately, unlike with kidney function, where we have our trusty estimated glomerular filtration rate, EGFR, there's no single liver function score that tells the whole story. Instead, we use a collection of tools and a whole lot of clinical judgment. So let's look at the Child-Pugh score first of all. It's a classic but not perfect assessment. This Child-Pugh score is a well-established tool in the world of hepatic impairment. So what's involved in the Child-Pugh score? Well, we look at the bilirubin. So this is a yellowish substance that's a byproduct of the breakdown of red blood cells. The liver is responsible for processing bilirubin and excreting it in bile. High levels of bilirubin in the blood, i.e. hyperbilirubinemia, can indicate that the liver isn't functioning properly. Then you have albumin. So this protein produced by the liver is essential for maintaining fluid balance in the body and transporting various substances, including hormones and drugs. So low levels of albumin, hypoalbuminemia, can be a sign of liver damage. Then we look at the INR, or the International Normalized Ratio. So this measures how long it takes for your blood to clot. The liver produces clotting factors, so a high INR can indicate that the liver isn't making enough of these factors. Then we look at ascites. So this is a buildup of fluid in the abdomen, which can be a sign of advanced liver disease. And then you have encephalopathy. So this is a brain disorder that can occur in people with severe liver disease. It's caused by a buildup of toxins in the blood that the liver is unable to filter out. So going back and looking at all of these factors that we inputted and graded on our Child-Pugh score, we get a total score, and the Child-Pugh score ranges from 5 to 15, with higher scores indicating more severe impairment. We want to have our patients to have a good grade of a lower score. Then another scoring tool that we can use is the NCI organ dysfunction criteria. And that's a more focused approach. So the National Cancer Institute Organ Dysfunction Working Group criteria offer a slightly different approach to assessing liver function. They focus on two key markers. So they look at bilirubin. As we discussed earlier, bilirubin is a waste product that the liver normally processes. High levels can indicate a liver dysfunction. And then we look at liver enzymes, so your ALT and AST. So these enzymes are found inside liver cells. When liver cells are damaged, they release ALT and AST into the bloodstream, causing elevated levels. It's like a broken pipe leaking water. So the NCI criteria categorize hepatic impairment as mild, moderate, and severe based on the levels of bilirubin and those ALT and AST liver enzymes. This can be helpful for guiding dose adjustments for certain chemotherapy drugs. So looking at the importance of context and clinical judgment in all this, right? So while the Child-Pugh score and NCI criteria are valuable tools, it's important to remember that they're just part of the puzzle. We need to look at the bigger picture, considering the patient's overall health, medical history, and other medications they're taking. For example, a patient with a slightly elevated Child-Pugh score but no symptoms of liver disease might be able to tolerate a higher dose of chemotherapy than someone with the same score but who is experiencing fatigue, jaundice, and other signs of liver dysfunction. It's also important to consider the cause of the liver impairment. So if it's due to a temporary condition like an infection or recent chemotherapy, the liver function may improve over time and dose adjustments may need to be revised. So here's where things get a bit tricky. Even with all of our tools and careful analysis, there are still grey areas when it comes to assessing liver function and adjusting chemotherapy doses. Many clinical studies using drug development rely on the Child-Pugh and NCI criteria, but these tools might not perfectly translate to all cancer patients. This can leave us making educated guesses and extrapolating data to try and individualize our recommendations for those individual patients. Additionally, the severity cutoffs can be a bit arbitrary. Is a mild impairment by one test truly the same as mild by a different system? This lack of standardization can make it difficult to compare research and create consistent guidance. But don't worry, we do have some guidance that we can look at. The guidance that we were talking about last week, the Krenz et al. And the updated Giraud et al. Document that was developed for anti-cancer drug dosing guidance in renal and hepatic impairment does have that section on hepatic impairment, which lists for each systemic anti-cancer treatment which dose you should go with based on the impairment of the liver and on which scoring tool has been used in research and in the clinical trials that have been developed to license these drugs. But overall, look, remember, managing hepatic impairment in cancer treatment is a dynamic process that requires ongoing collaboration, individualized care, and a healthy dose of clinical judgment. We're trying to work together. We can navigate the complexities of liver dysfunction and ensure that our patients receive the safest and most effective chemotherapy possible. But let's look now at the domino effect of hepatic impairment on chemo. So when a liver function takes a hit, it's not just about whether a drug gets broken down faster or slower. It truly sets off a cascade of potential problems that can impact every aspect of patient's treatment. So let's break that down. So first of all, right, you have the great toxicity risk. For many chemo drugs, a compromised liver means they hang around in the body for longer than expected. This can lead to severe side effects, even if the initial dose seemed completely reasonable. Imagine a chemo drug designed to cause a bit of nausea suddenly triggering uncontrollable vomiting, or a mild drop in blood counts turning into a life-threatening situation. It's our job to anticipate and try to prevent these scenarios. For example, the drug irinotecan is converted to its active metabolite SN38 in the liver. In patients with moderate hepatic impairment, the area under the curve, AUC, of SN38 can increase by over 100%. This heightened exposure can lead to severe neutropenia and diarrhea, which can be dose-limiting toxicity. Then you have the prodrug dilemma. So remember those chemo drugs that I said that needs to be activated by the liver? So if the liver isn't up to par, insufficient amounts of the active drug are formed. This can make the treatment less effective, potentially allowing the cancer to progress while we think we're fighting it. So capecitabine is a classic example of a prodrug. It's converted to its active form, 5-fluorouracil, 5-FU in the liver. In patients with severe hepatic impairment, the conversion to 5-FU may be reduced, leading to decreased efficacy of the drug. And it's not all just about metabolism either. So here's where things get even a bit more complicated. The liver is responsible for excreting many drugs and their metabolites into bile, which is then eliminated in the feces. When the liver is impaired, this biliary excretion process can be disrupted, leading to a buildup of drugs and metabolites in the body. This can increase the risk of toxicity, especially for drugs that are primarily eliminated through this biliary route. And also, blood flow matters. So the liver receives a massive amount of blood flow, and when liver function is reduced, this flow can be altered. This is particularly important for drugs whose clearance is highly dependent on blood flow to the liver. For example, the clearance of drugs like doxorubicin and epirubicin can be significantly reduced in patients with severe hepatic impairment, leading to increased toxicity. And then you have the protein problems. Many chemo drugs hitch a ride in the blood by binding to proteins, particularly albumin. The liver produces albumin, and when that liver isn't doing well, there's less albumin flowing around. This means that there's more free bound drug, which can sometimes lead to unpredictable side effects, even if the total amount of drug in the body isn't necessarily higher. So drugs like paclitaxel and docetaxel are highly protein bound, and their free fraction can increase in patients with hepatic impairment, potentially leading to increased toxicity. And then there's the individuality factor. So it's not a one-size-fits-all situation. And here's why. So the type of cancer. An aggressive cancer with a high chance of relapse might warrant taking more risks with chemo dosing than a slow-growing tumor, even if the patient has some liver impairment. For example, in a patient with advanced hepatocellular carcinoma, the potential benefits of sorafenib may outweigh the risks of dose-related liver toxicity. And then you have your treatment goals. So are we aiming to cure the cancer or extend life while maintaining quality of life? This influences our willingness to potentially accept a higher level of toxicity. For instance, in palliative care settings, we might prioritize quality of life over aggressive dose escalation, even if it means slightly lower efficacy. And then you have to look at the patient themselves and their resilience. So a frail, elderly patient might not tolerate the same side effects as someone younger and fitter. We have to factor in their overall health, not just the liver test numbers. This is where a multidisciplinary approach involving oncologists, nurses, pharmacists, and other healthcare professionals is crucial for tailoring treatment plans to individual patients. And similarly to what I said last week with the renal impairment, right? Why can't we just do our dose adjustments simply? The liver's struggling. I've told you the liver is struggling, so why don't we just lower the chemo dose? So it's not just that straightforward. There's a delicate balance with many chemo drugs. Too little, too late. Lower the dose too much and we risk under-treating the cancer. This could mean it progresses faster or becomes resistant to the drugs we do have. So it's a constant balancing act between efficacy and toxicity. Again, similarly to the renal impairment, there's a narrow therapeutic window for these drugs. So for many of those chemo drugs, the difference between an effective dose and an unbearably toxic dose is tiny. Dose reductions have to be calculated meticulously, especially for drugs with serious side effects. We need to find that sweet spot where the drug is doing its job without causing undue harm. And then there's the uncertainty with pros. With those drugs that need liver activation, the severity of impairment will greatly impact how much to dose adjust. Unfortunately, we don't always have great data to predict this, since it depends on specific enzymes within the liver, which we typically don't measure individually in patients. This is where clinical judgment and close monitoring become even more important. Dealing with hepatic impairment in cancer treatment is like walking a tightrope. We constantly have to balance the potential for side effects with the crucial need to effectively fight the cancer. But as I said, those documents that are developed by Krenz et al. And then updated by Giraud et al. Give a great insight into how we approach dose adjustments in hepatic impairment. The NCCP are updating their guidance to match the updated documents by Giraud et al. And replace the old London Cancer Alliance doses. So this is a great asset and great resource for us to use when we are faced with those consequences of dealing with patients with hepatic and renal impairment. So, thanks a million, guys. I hope you found this episode informative and helpful. If you have any questions or comments, please don't hesitate to reach out through the feedback form in our show notes. As always, we've included an example CPD document to help you easily fulfill your CPD requirements. As I said, if there's any nurses or doctors listening and you want help or you want to use this podcast as a means of gathering CPD for yourself, let me know how I can achieve this and I'll try and put in the groundwork to get that done for you guys. And as always, I'll end this podcast with this important disclaimer. This podcast is for educational purposes only. Remember, the field of cancer care is always advancing, and new research may lead to changes in treatment approaches or protocols. Always consult with your own team for personalized guidance and discuss any information from this podcast with them. Seek information from trusted, local, and national resources for the most up-to-date recommendations. Thanks for tuning in again, guys, to the Irish Haematology Oncology Podcast this week. And until next week, take care.